Hello, welcome to our webinar on exposure assessment, when, why, and how. My name is Pam Susie, and I'm an industrial hygienist with OSHA consultation. So during the webinar, if you'd like to enter any questions into the chat, please feel free to do that. I'll do my best to try to respond in real time, but if for some reason I can't, I will respond, and you can check our webinar, our website, and we'll have them up their responses within 7 days. So why do we do exposure assessment? We do it in terms of the big picture, ultimately to try to make sure that workers go home safely every day, and not only now, but into the future, so they can live to draw a retirement and live healthy into old age, and not have to suffer with occupational diseases like asbestosis, silicosis, bladder, lung cancer, diseases which could have been prevented. In 2019, 5,333 workers were killed on the job, but an even larger number were estimated to have died of occupational diseases. So we do exposure assessment to try to prevent these diseases. I'm going to show you a video that was produced by the Department of Labor when they were in the process of doing the silica rulemaking.
And I feel it to be my duty to make this report available to the working people of the United States and to their employers. This report shows how silicosis occurs, where it occurs, and what the disease is. The report emphasizes that these control measures, if conscientiously adopted and applied, that silicosis can be prevented.
When I first seen Francis Perkins' video, I was just outraged that in 1938, 60 experts spent just a year to figure it out. And to really make it simple, turn the water on or turn the vac on. My dad was a sandblaster for several years in his late 20s. Shortly after that, he became short of breath. We didn't know what it was. He had a couple collapsed lungs, and then finally the diagnosis came, it was silicosis. It took about 5 years to kill him, and we got to watch. The toughest thing was watching him come home when he couldn't work no more, and literally fell on the ground and cried. He said, "I can't do it no more." So the impact is huge. Anyone that's ever lost anyone knows exactly what I'm talking about, whether it's cancer or a sudden fall. But watching a loved one suffer is a real human toll. They didn't know then, and most people don't know now, about the hazards of working around silica, dry grinding and cutting and polishing material that produces silica dust. The modern workforce can work safer. The silica standard can save lives. It will save lives. And frankly, it's going to save a lot of money. If over 50,000 people are dying every year from diseases they contract at work, some of them silica, imagine the cost. It's time to get the word out and let them know about this.
And I feel it to be my duty to make this report available.
So when we talked about those 5,333 deaths in 2019, 154 of them were Pennsylvanians. And in terms of injuries and illnesses, they estimate 137,000 of those that year too within Pennsylvania. But the good news is that we ranked number 8 in terms of one being the best nationwide. We were right behind California, so that was good news. Also, when we talk about exposure assessment, the health hazards that we're focused on fall into one of 3 categories: physical hazards, chemical hazards like particulates, welding fumes, dust, things like we just looked at, vapors, solvents, gases, things like methane, welding gases, argon, things like that. Biological hazards, COVID, for instance, would be a biological hazard. Some more physical hazards include noise, heat stress, radiation, people who work in nuclear plants, ergonomics is pervasive in a lot of industries. A nice publication that you might want to look for if you're interested in this is a document NIOSH put out on, they talk about research needs for exposure assessment, but they also give you an idea of the process of occupational exposure assessment. And it includes all the way down from identifying and characterizing workplace exposures, all the way up to, estimating workplace exposures across populations and doing exposure response studies. So why do we do exposure assessment? There's 3 major reasons: surveillance, and we'll talk a little bit about that, but that's tracking occupational disease through epidemiology studies, risk assessment, compliance, and then diagnostic purposes. So going back, 100, 200 years ago, before there was such a thing as industrial hygiene as a profession, doctors were the first ones who kind of put 2 and 2 together and figured out that, there was a relationship between what you did for a living and disease in many cases. And there was one particular doctor, this Dr. Bernardino Ramazzini, who lived in the late 17th century in Italy. And he would actually go to where his patients worked and talk to them about what they did and observe the conditions they worked in. And he wrote this book that from the Italian translated to Diseases of Workers. And he described the diseases among 54 different occupations. And because of that, he's known as the father of occupational medicine. And there's this one quote that he has where he talks about these affectations gradually arising from particular postures or unnatural movements of the body. And he talks about how, the workers stand all day or sit stooped in awkward postures, and, how it winds up causing diseases among these workers from these irregular motions and unnatural postures. And it sounds very similar to what we see today, but we call it, cumulative trauma disorders or repetitive motion injuries. So same problems that occurred 300 years ago, we're still seeing today. Now, going forward, 100 years later or more, Alice Hamilton was our mother of industrial hygiene. She was also a doctor. In fact, she was the first woman physician, first faculty member actually at Harvard, worked at Harvard, but she also was a doctor. And if anyone's interested in her, I really recommend you look for a publication in the autobiography she wrote called My Life in the Dangerous Trades. And also in terms of practice of industrial hygiene, that's defined, classically that's defined as the protection of the health and well-being of workers through the anticipation, recognition, evaluation, and control of the hazards in the workplace. But she did very much what Ramazzini did, went into the workplace and really studied the hazards. She did a lot of work around lead. Around the turn of the 20th century, one of the first big industrial illnesses that was identified was that of dye workers. And there was a German doctor who he identified 3 cases of bladder cancer among 45 workers, which, this is already considered a rare disease. So to see 3 cases among just 45 workers is pretty astounding. And then the International Labor Organization, not long thereafter, wrote a book, a monograph rather, that identified benzodine and BNA as the suspect agent within the dyes that was causing the problem. So, you know, along with the rapid industrial growth came also the emergence of these illnesses. And 20 years later, DuPont opened up Chamber Works, which is in Deepwater, New Jersey, that produces benzodine and BNA. And for those of us who live in southeastern Pennsylvania, it's just over the Delaware River from here. And if you drive from Delaware, you can go over the Delaware Memorial Bridge, you can't miss it. It's a big monstrosity, you know, continued to manufacture other things, but there they had a really poor handling of the industrial materials and products. And in 1932, they identified their first bladder cancer case. And 4 years later, they had 83 bladder cancer cases. In 1938, not much later, the United States Public Health Survey did a screening down in North Carolina of asbestos textile workers. Unfortunately, before they got there, the company had fired 150 of the employees that they had planned to screen, but they were able to track down 69 of them. And 43 of those that they tested had asbestosis. So they found that 68% of those who were exposed for 10 years or more, who had exposure to 5 to 10 millions of particles per cubic feet of air, had asbestosis. So really high rate. And then 30 years after that, in Mount Sinai School of Medicine, Dr. Erling Selikoff did some studies of asbestos workers. And he found that the rate of lung cancer was 7 times that of workers in a similarly matched group. And then not long after that, the Asbestos Workers Union approached Dr. Selikoff because they just were really seeing a lot of cases within their union. And it's really hard to overstate the amount of respect that the occupational health community had for this man and the workers who were impacted by asbestos. In this obituary, they talk about that, he set up a lung clinic in Paterson, New Jersey. And after he set it up, he began to see patients, including 17 workers from an asbestos plant. And within a few years, 15 of those would die, 14 from lung cancer, asbestosis, or mesothelioma. And he did a much larger study of insulators that involved 17,000 workers. And among those cases, he found a lung scarring among workers who had worked with asbestos for less than a week. So I remember talking to asbestos workers union representatives who would tell me that, they began to suspect there was a problem because they had so many members who would die in their 50s before they could even collect their pension. And they had a very flush pension fund, but, not for good reasons. So that's when they started participating in these studies. So for good reason, you can see why the OSHA was signed into law in 1970. It was a bipartisan effort. Nixon, signed the bill into law. And there was a lot of rapid development standards. There was standards for lead, carcinogens, cotton dust, set up the OSHA Training Institute, established the OSHA consultation program, which allows us to do things like this webinar, to conduct visits among PA employers. And a lot was accomplished in just a few years, but there's still a lot to be done. One of the landmark cases and standards that took place, was developed, and court cases occurred, was in 1978. The benzene rule was published, and benzene is causes blood diseases like leukemia, aplastic anemia, and it's also possibly causes lymphoma. So they published the standard, which would have lowered the PEL to 1 parts per million in 1978. But the courts basically shut it down, or they stayed it. So it's, what you need to know is that like from 75, and it's been upheld in subsequent years, has ruled that there must be a significant risk for OSHA to lower a PEL, which means they have to do a lot of risk assessment studies to document, justify why they're lowering the PEL. And they've determined, the courts in a kind of somewhat arbitrary way have set significant to be 1 case per 1,000 workers. So the Fifth Circuit Court of Appeals put a stay on the rule and did not then lift it until 1987. So there was like a 9-year delay on lowering of the PEL. So this study, this paper was published by Philip Landrigan and Nicholson, who actually worked at Mount Sinai. They followed up in Dr. Selikoff's shoes, and they did a study looking at, for the 9 years that the benzene standard was in place at that higher PEL of 9 or 10 parts per million versus 1 parts per million. They looked at what is the estimate of workers who would be likely to get leukemia because they weren't protected at the lower level. And what they came up with is that there was a likelihood that 30 to 490 excess leukemia cases occurred because of the court delay. So, that's an example of, risk assessment studies. But in this case, it's a risk assessment of, what took place because of the court delay. And, it also is kind of interesting because in this case, there are 238,000 workers exposed to 7 occupational categories in the benzene arena. And if you've got 1 case per 1,000 workers is seen as a reasonable risk, then that's basically saying that 238 workers are at risk of getting cancer at the current PEL, and that's considered an acceptable risk. So I don't know if that's really that acceptable, but that's how it is. So who does exposure assessment? There's really a number of disciplines involved at different levels of how we do it and what we do. We just learned how occupational physicians, especially in the early years, were really important in identifying diseases that were associated with exposure to hazardous agents. And they still are involved, especially when you look at diseases across the overall population. And then epidemiologists and biostatisticians are involved in that too. But then when you look at exposures in the field and data gathering, like this young man here is doing, industrial hygienists are typically the ones who do that. Epidemiologists, in terms of how you describe what they do, well, the CDC describes them as disease detectives. That, they go out and try to identify what populations are most at risk, determine how to control the spread of disease. They often are physicians too, but they could be veterinarians or other types of health professionals. And, they were the folks who were probably most active, the people we heard most about during the COVID-19 pandemic. They were trying to figure out, where did the virus start, and how do we figure out how long people must be quarantined after they're exposed, things like that. And we saw how things changed, and it changed as we learned more. And it was people like this, epidemiologists, who were helping us figure out more as we went along. So industrial hygienists, professional industrial hygienists typically have at least a bachelor's degree in sciences or engineering with coursework in industrial hygiene in addition to whatever their base education is, and at least 4 years of professional experience. And they usually gather or supervise the gathering of exposure data in the field. But they are typically out there kind of in the trenches more so. And they're either evaluating exposure data or implementing and evaluating controls. So the second reason we do exposure assessment, and is probably the most common reason we do it, is for OSHA compliance. And when we're trying to determine compliance, we're usually comparing against exposure limits. And the ones that employers are usually most concerned with is comparing exposures against OSHA permissible exposure limits, or PELs. The problem is that there are limited numbers of PELs for one thing, but the ones we have, the majority of them are very dated. They came into being around 1970, and they've not been updated for the most part. OSHA has 16 comprehensive standards, but for the most part, the ones that were put in place in 1970 have not changed. When OSHA came into being in 1970, what they did was they adopted the ACJH, American Conference of Government Industrial Hygienists, threshold limit values, the 1968 TLVs, which were part of the Walsh-Healy Public Contracts Act. And that was fine back then, but now they're still in use, and that they're 50 years old, and the TLVs, we'll talk about them, are updated every year. So it's not ideal that we're using 50-year-old limits. But employers, they have to do monitoring to verify that they are below those limits, even though they are old, it's what we have. And if they're needed, the employer needs to implement engineering controls if the exposures are not below the limits. Unless for some reason that's not feasible, then they have to utilize PPE instead. And one thing that's not, I think, noticed very much, but it does say in the standard that industrial hygienist or a technically qualified person has to be involved in overseeing the approval and helping the employer with those measures. So OSHA does recommend that employers consider other criteria in evaluating workplace exposures, beginning with OSHA during the David Michaels era during the Obama administration. OSHA began to publicly acknowledge that their PELs were dated, and they encouraged employers to consider looking at Cal OSHA, which, even though they're an OSHA state plan, they updated their PELs, so they draw from more current threshold limit values. NIOSH has health-based criteria documents that publish recommended exposure limits. ACJH is a private nonprofit that has volunteer committees that generate new TLVs that are updated every year. They don't update all of them every year, but they do look at subset and continuously try to review new sets of TLVs every year. So the TLVs are published in a little booklet, and a good thing about these too is they publish the documentation of the TLVs, so you can get the studies and see how they arrived at what they did. And like I said, these are the basis of the original PELs. They just were from 50 years ago. Another thing that's good to note is that OSHA did try to update their PELs with what were the current ACGH TLVs at the time in the late 1980s, but that was challenged and the court threw it out. And so they're back to square one. So a nice resource on the OSHA website is the annotated PEL tables. And there they list both the PELs, but also the Cal OSHA PELs, the NIOSH RELs, and the ACJH 2019 TLVs. But they just have the 2019 TLVs. If you want to get more current ones, you have to order the TLV booklet from ACJH. And then other standards that require exposure assessment in a more detailed manner is the comprehensive health standards, like for lead, silica, benzene, methylene chloride, hexavalent chromium. They require initial monitoring and then the prescribed periodic monitoring. Usually it's like every 3 months, every 6 months, depending on what the exposure levels are. And then a couple of the construction standards have a novel approach to monitoring. Like in the case of lead, they have interim presumed exposures, whereby for certain standards you have to provide PPE until you do monitoring. For silica, there's a table 1 for certain tasks that if you elect to follow table 1 and follow the very detailed instructions, or they're not very detailed, but you have to follow to the level of detail provided, you don't have to do monitoring. And then finally, the respiratory protection standard, you have to really have to do monitoring, or you should do monitoring to make sure that whatever respirator protection you're using is adequate, because the respirator has a certain assigned protection factor, and you don't really know if it's adequate unless you know that the exposure levels are below that level. And then finally, diagnostic purposes would be if you're testing to make sure that the exposures, the exposures are below that whatever the OEL is, and that your control your testing is working. Or for hotspots, like I was at a site where the employer had hydrogen fluoride being produced or utilized, and they wanted to see where in the process they might be generating exposure so that they could concentrate on making sure they were closing up any release at that location, which was a wise approach to trying to control the process. And here you see that this was a tuck pointing operation, and you were basically testing the control using a static pressure measurement device. So the mechanics of how we measure exposure, what you see here, we're just using a simple pump and a cyclone to measure out respirable silica. On the left, the young man there, he's using a bubble meter to calibrate the pump, so we know the exact flow rate in liters per minute. I'm on the right pointing to a cyclone, which is connected to a sampling cassette, and that cyclone separates out the large particles that drop off into the cyclone, and the small respirable particles that get in the lung go up into the cassette. So we get the mass of respirable dust go in this cassette, which gets sent to the lab. At the end of the day, whenever we get the lab results back, we have the mass, we have the volume from the liters per minute, which we can then use the mass divided by the volume, and we can get micrograms of, say, respirable silica per cubic meter of air ultimately. Sampling methods are available from NIOSH and OSHA for any chemical that you want to sample. And they give us pretty much all we need to know, which is the pump flow rate, the sampling media we need to use, the minimum and maximum volume of air. And once we know, like I said, how much air we need to pull through the pump, or how much air we did pull through the pump in this case, then we've got a volume of air. And once we have the results, we have concentration. So we have like X micrograms per lead, if we're sampling for lead per cubic meter of air, and we can compare that to the lead PEL, which is 50 micrograms per cubic meter of air. And here's some air monitoring equipment. On the left, there's a dry cal, which we use as a primary standard, which is something traceable to a primary standard that's used to calibrate the pump. In the middle is the whole sampling train, the tubing, the pump, the cassette, and just another picture of it with it connected to the calibration device. And then just some other considerations regarding the tools of the trade, so to speak. We have to consider which is more appropriate, direct versus continuous reading sampling. You know, if we're doing confined space sampling and say we're concerned about hydrogen sulfide gas or something like that that could kill someone that day, we're not going to do continuous monitoring because that's there's no time to wait for a lab sample to come back. So that's a consideration. Quantitative is not the only thing you want to collect when you're in the field. You want to also get qualitative information like variables about exposure. These pictures were taken some time back when we were looking at, this was another job I was on where we looked at silica exposures among painters and bricklayers, and we were looking at things that might impact exposure, you know, task variables, what type of materials are in use, ventilation, things of that nature. And that's just as important, or that's, you need that information to help figure out what's going to impact exposure levels. And then passive dosimetry sometimes is something to consider, that there's not so many validated methods, but this is a little piece about a nail salon where they were using material that had phthalate plasticizers in it. And, you know, they didn't want to have these noisy, bulky pumps in the nail salon, I suppose. It's kind of off-putting for the customers, but that seemed to work. And then the other problem, though, was there's no occupational exposure limits, which is a problem with a lot of chemicals these days. There's over 85,000 chemicals according to EPA, and there's only about 1,000 occupational exposure limits. So what they did here was they compared the results to background levels in the homes and also in industries where you would expect to see phthalates. And what they found was that the concentrations in the nail salon were 30 times what you'd see at home and 10 times higher than in this other type of industry where you might see phthalates in the environment. Another reference you might want to go to if you're interested in alternative ways of evaluating exposure where there aren't OELs is this NIOSH document on occupational exposure banding, banding, excuse me. And then finally, wipe sampling is a good thing to do with certain things like lead, because, you know, air inhalation is not the only way we're exposed to chemicals. Ingestion, accidental ingestion by getting contaminants on our hand or food, smoke, getting it in our mouths that way. Some things get through the skin. There are some agents that have biological exposure indices like lead, but in these instances, wipe sampling is a good way to look at the hygiene program and the potential for exposure that way. This was a painting job in New Jersey, and you know, there was at that point, this was the early 2000s, a lot of lead abatement type work going on, industrial bridge painting. I'm not sure how it is now, but once they had things under control in terms of airborne lead exposures, the problem of the ingestion of lead was an issue, and trying to get hand washing in construction sites was a problem. So that little hand washing station doesn't look like much, but that's a big accomplishment, just getting that on a construction site. So this is some language from the OSHA chemical exposure health data page on the OSHA website. And they talk a little bit about what they do and they don't do. And basically they say that, you know, they're not necessarily collecting representative data. What they are looking for is worst case data. And, you know, that's certainly understandable because they're doing compliance monitoring, but that's different than the kind of data that you need for epidemiology work. And one problem with worst case monitoring is we really never know if we captured worst case, and there's a fair chance we didn't. The other thing is that when you're trying to do trying to do sampling to get a representative sample, the first rule is don't ever try to always do random sampling. That, you know, if you really want to characterize the population of exposures and get, you know, figure out what the mean, the standard deviation is, then you don't want to try to get a worse sample. You want to get random samples. So, you know, there has been a lot of work done looking at exposure analysis and how exposure data does tend to operate, you know, and one thing that's been found is that it really varies substantially. And the good thing about engineering controls is it not only reduces the magnitude of exposure, but it also reduces the variability. There's one study that Steve Rappaport, it's a guy who's known for doing a lot of good work in this area. He found that among 233 workers across 4 different trades, 59 construction sites, you would have tremendous variability between exposure, so much so that among one trade, the painters, I think it was, who had the highest exposure, the highest measurement was over 5,000 times the lowest measurement. But that for all these trades, the exposures were 44% of them exceeded the silica threshold limit value. So, you know, typically wherever we're at, we usually don't have that many measurements to work with. So trying to figure out whether the actual exposures going on exceed the OSHA PEL can be a problem. And then again, the problem is exposures may vary by 10-fold. So this little graphic here is meant to represent what actual exposures are. So you see, you know, over time, January through November, the black dots are what actual exposure measurements may be. And then the green dots are the 6 measurements we may collect. So the question is, how do we really get an idea, a good representation of what's going on? And so now there are free tools you can go on site and get. So there's expostats.ca. You can go on this website and just plug in your data, and it will give you some idea about what your exposure distribution is. And it'll also give you like an idea of whether your exposures are in control, not poorly controlled, or moderately controlled. And Professor Jerome Lavalier from University of Montreal is someone who's been the lead developer of this and was helpful in helping me with some of these slides. And IRSST, which conducts and funds research in occupational safety and health, also has supported some of this work, and Jerome has worked with them in the past, provided me, also should be credited with this, because they also funded some of the work. So like I said, the way it works is you input a small sample of data, and based on statistically informed decisions, they provide you with an evaluation of the probability, the 95th percentile exposure data exceeding the occupational exposure limit. So the next few slides, I'm going to walk you through some of the underlying statistics, but you don't have to really know how to do statistics to use the website. The end output is information on how well exposures are controlled. So these aren't the easiest things to get through, but as Dr. Lavalier tells his students, it says, unlike safety professionals, industrial or occupational hygienists, as they're called in other parts of the world, will never know if they got it wrong. So it's really true that industrial hygiene, the chronic illnesses don't develop for 10, 20, 30 years from now. So we're not there to know if we did our job. So, you know, we have to use what tools are available. And unfortunately, they're not always that easy to use. But to get started, what we're looking at here on the left are, this is supposed to be 177 lead exposure measurements collected for 6 workers performing the same task for 1 year in a gasoline additive manufacturing industry. So those are the random measurements. You've got 0 to 60 micrograms per cubic meter, and lead, the PEL is 50 micrograms per cubic meter. In the middle bottom, same data, concentration now is a bar graph by count. So this is just, like clustered together, you've got 20 that fall in the range of whatever it is, 5 to 10 or whatever, 35 in the next concentration group. It's just basic, count them and put them in Excel in different, ranges by concentration. And everything in gray, that's just, all of the data falls into that, shape. And that you notice is the same shape as this curve, like everything under that curve is just like everything under that histogram is called a probability density curve. So when you try to interpret a probability density curve, it's just like interpreting a histogram. Everything under the line represents exposure. There's less exposure measurements out in these far tails, the left and right. So these represent very low exposures, very high exposures. Most of them, though, are kind of like, in that mid-range, but they everything in the gray area sums up to 100% of the exposures, but most of them are in that middle point. So those of you who took statistics in high school or college, you remember the bell curve, and what we just looked at was the normal bell curve when we talk about statistics. So you can use statistics and normal bell curves to make a lot of reasonable estimates that could come in handy if you're estimating the likelihood of exceeding an exposure limit like an OSHA PEL. That's the green line's that bell curve. The problem is the exposure data, like a lot of natural phenomena such as human heights, tend to lean left, like this pink line. So most of the exposure are in the smaller concentration range. And that's true of, like, say, heights. So there's only a handful of men that are tall enough to play in the NBA, relative to the general population. They follow this, what they call a log normal distribution. But we can adjust that and make that into a normal curve. And I won't get into all that, but we can basically make the adjustments so we can use it just like a normal curve to make estimates. And so going back to the lead additive plant, this is the same data, but presented another way. It kind of looks like a pool, right? And that solid line is your 95th percentile of all exposures. And that dotted horizontal line is the PEL. And so basically you see that most of the exposures are below the 95th percentile. And most of them are below the OEL, but there's a few that are up above not only above the pool line, if you're looking at a pool, but are above the OEL. And so the density curve is just the same data. It's all the shaded area under the curve is the exposure data. And then the OEL, the vertical line, is the same as what's next to it, but where it's horizontal. And you can see that there's a little bit of white area there where there is some exposure. That's the 5% that, where there's still a little bit of activity there, but not much. So anyway, looking at that with the probability density curve, it's a little easier to see statistically. All right. So all that just to give you an idea of what goes into the statistics of it, but you don't have to worry about it. But this is the bottom line answer. So, and this is not the lead, but this is what it would look like if, say, you had data with an exposure limit of 200. These are the measurements: 28.9, 19.4, and you can see for yourself, they're all under 200. But if you put that in there, because it's so variable, your result would be the probability that your results would be, your 95th percentile would be below the OEL is like 50%, which is not great. You want a much higher probability than that. So it's poorly controlled, which would mean you'd have to take action. And this is just a little more detail about that, which we won't go into, but it has to do with it. This factors in a little more leeway because the French and the British came up with an approach that is a little less stringent than what's been done in the past. But so instead of it just being 5% or you're either in or out of control, they allow this middle ground where, if you're between 5 and 30%, they consider the risk moderate and it's under control, but there's very little safety margin. So if you're still with us here, I appreciate your tenacity and your commitment to safety and health. Also, if you have never used us for consultation services, I really encourage you to do so. I feel like you've been a help to other folks. I think we can help you. This is our contact information, our website, and our phone number. And we have a webinar coming up in May 11th at 10:30 a.m. on workplace safety and the automotive lift, which is a very important topic. And I appreciate your attention. And like I say, if you have any questions, please feel free to put them in the chat area.